So after the primary survey is completed, the patient should be in a stable condition. Their essential life signs should be stable. So their blood pressure should be stable. Their heart rate should be stable. Their blood oxygenation should be stable. And at that stage, we can go on to the secondary survey. So the secondary survey only takes place once vital functions are present and stable. And the secondary survey is very important because injuries can be missed. Make no mistake about it, injuries can be missed. I'm sure quite a few of us have gone onto the ward the morning after an injury or a trauma and actually found out that there was injuries that had been missed. So things can be missed, we need to make sure they're not. But it's actually quite difficult because after trauma there might be reduced levels of consciousness. So the patient can't report where the pain is. Or sometimes there might be an injury that's not associated with significant amounts of pain. That can be the case as well. But other times the converse is true. After trauma, everything can hurt. So maybe like me, you've been knocked off your bike or traumatised in some way, and absolutely every part of you seems to hurt. So an injury could be missed because all the parts of the body are in pain. And the part of the body which is badly injured will be in pain as well, but everything else hurts, so you don't localise and identify that particular part of the body. Again, meaning an injury can be missed. And also in the secondary survey, we want an accurate Glasgow Coma scale if one hasn't been done before. So the secondary survey, it's a thorough examination and it's also a thorough history taking. Very often we can get more information from assessing the patient by taking a history than we can get from the actual physical examination. So let's think about taking history now. Now, a lot of people talk about an ample assessment, A-M-P-L-E. I've changed that slightly. I'm going to call it a sample assessment, S-A-M-P-L-E. So first of all, where does the information come from? Well, we're going to get information from the patient themselves if they're conscious and able to talk to us. But information can also come from family members, friends and relatives. If they come in with the patient, grab them, keep them somewhere safe because we might need to get information from them about the particular patient. And also pre-hospital staff can be very important in giving us information. Paramedics, for example, can give us very useful information about the type of accident, the situation of the accident, and other things that can help us to make a thorough assessment of our patient. So let's think about sample. S is for signs and symptoms. What signs can we see and what symptoms are the patients reporting to us? So S for signs and symptoms. A is for allergies. And of course, we always need to know for any patient in our care if they are allergic to anything. Now, it could be they've been exposed to something before they came into hospital and are suffering from an allergic reaction already. It's not that likely in a trauma situation, but what is quite likely is that we are going to give them some drugs at some stage. And before we do that, we need to know if there's any possibility that the patient is allergic to a particular drug. So antibiotics, for example, we may want to give antibiotics. Very important to know if the patient is allergic to antibiotics. We're almost certainly going to give analgesia. For example, in the trauma situation, it's quite common to give something like a non-steroidal anti-inflammatory drug, ibuprofen, with paracetamol, possibly even with codeine in addition. And some people are allergic to non-steroidal anti-inflammatory drugs, so we wouldn't be able to give them the ibuprofen. We'd have to give them paracetamol and codeine without the ibuprofen. So very important to know about allergies. Then we need to know about medication. Is this patient on medication already? Now, when we know what medication the patient is on, that's going to tell us a bit about the underlying medical conditions that the patient might be suffering from. Because obviously if someone's on medication for asthma, there's a risk they're going to be asthmatic. If someone's on medication for diabetes mellitus, then they're going to be diabetic. So medication tells us about the past medical history and current medical history of the patient. Also, medication can alter our observations. Maybe a classic example is beta blockers, which can give rise to a bradycardia, a relatively slow heart rate. Or if a patient's on medications, they might need to carry on with those medications. We might need to keep giving them the medication. Or the medication can affect the condition of the patient significantly. For example, if a patient's on aspirin or warfarin, then warfarin is going to be an anticoagulant, meaning that there could be more bleeding. So we might need to consider giving an antidote in that case. But basically we need to know what medication the patient is on. P is for past medical history. We need to know all we can about the patient because that's going to influence their ability to withstand the trauma, and it's going to influence all the treatments that we're going to give. The past medical history. And P also stands for pregnancy. We should always consider the possibility that any one of our female patients is pregnant. There could be damage to the fetus or compromise to the fetus. Or it could be that we want to send this patient for x-rays or scanning, which could involve ionising radiation, and we don't want to x-ray pregnant women. So always check to see if your patients are pregnant. It's very important. L stands for last meal. That helps us to assess how much there is likely to be in the patient's stomach, especially if the patient has a low level of consciousness, because they could vomit and then aspirate in and inhale vomit into their lungs, causing potentially immediate choking, but also causing aspiration pneumonia. So if we know what's in the patient's stomach, we can hopefully take protective measures to protect the upper airway. And then E, S-A-M-P-L-E, E stands for the events of the accident. The mechanism of trauma should be established as far as possible, because the mechanism of trauma is going to give us a lot of keys, a lot of clues really, into what injuries might actually be present. So the mechanism of injury from the events at the time of the accident. And E also stands for environment. What was the environment at the time of the accident? So for example, is there any possibility of contamination with toxins? Is there any possibility that the patient was irradiated? So signs and symptoms, allergies, medication, past medical history and pregnancy, last meal and events and environment. A sample assessment. S-A-M-P-L-E. This is the secondary survey. So sample is the history-taking part of the secondary survey. The next part is the physical examination. And this is a head-to-toe survey of the patient. And that's a good way to do it. Start at the head and then work your way down. Head-to-toe examination. And bear in mind that really there's 2 or 3 categories of trauma that we can think about. And they're blunt, penetrating, and thermal. They're the main classifications of trauma. So thinking about blunt trauma first of all, where there's a blunt injury without penetration. And blunt injuries, of course, are very common after falls, or even trips, or falls from a height. And of course, after road traffic collisions, there's very often blunt trauma. So we want to consider whether the patient's been wearing a seatbelt or not, for example, whether they've hit the head, whether they've hit the chest. Thinking about blunt trauma. And the next type of trauma is penetrating, where something's actually got stuck in to the body. For example, stabbings can cause penetrating trauma, or gunshot wounds can cause penetrating trauma, or any form of impalement where something has been stuck into the body. So we're thinking about blunt and penetrating, but also thinking about thermal trauma. Now, most commonly this will be burns, but of course it can be cold as well. But if someone's had burns, then that's got quite a lot of implications for the way we manage the patient. For example, patients are often transported to hospital after burns with damp towels on them, and they've had a lot of water to get rid of the heat from the burn. And that can give rise to hypothermia, burnt patients are prone to hypothermia, which we want to avoid. So in that case, we'd take the patient's temperature and prevent hypothermia. And as well as that, with thermal injuries, if the patient's been in a smoky environment and they've been burnt, then they might have inhaled very hot gases. And we can look in the top of the patient's nostrils and see if there's any singed hair that would indicate the patient's been inhaling superheated gases. Now, why is it very important for us to realise if a patient has been inhaling very hot gases? Well, these hot gases can go down into the airway and start an inflammatory reaction in the airway. And when the patient's first admitted, they might be breathing normally, but then as the thermal injury causes an inflammatory reaction in the airways can start to swell and block off, and these patients can asphyxiate. So we need to monitor them very carefully and have a high index of suspicion for swelling of the airways as a result of the thermal injuries. Or if someone's been in a smoky environment, they might have inhaled a lot of carbon monoxide. The skin can become pinkish, the lips can classically become a cherry red colour. And when we put an oxygen saturation probe on the patient, that does not tell us whether the patient has a lot of carboxyhemoglobin in their blood or not, because oxyhemoglobin and carboxyhemoglobin both register the same on oxygen saturation probes. So we need to think, has this patient been exposed to carbon monoxide, and what implications again has that got for our care? And we want to look at the level of consciousness that the patient has. What is the history? So for example, some patients might be knocked out at the time of the injury, but then come round by the time they get into our care. That's quite important to know about, because if a patient was knocked out, that means they've had probably quite a lot of trauma to their head, but then they could wake up as the immediate concussion wears off, but then they're prone to developing secondary brain injury, for example, an extradural hematoma. So always be aware that patients could be coming in, talking to us, and yet their level of consciousness could deteriorate significantly after that. Some patients can talk and die. So these patients need monitored. So is there a history of unconsciousness? Was this patient knocked out at the time of the trauma? Very important to try and work that out. And then we can do a head-to-toe survey. Now, I'm not going to tell you how to do this. This depends on your clinical skills. But let's think about heads, for example. So is there any internal head injury? Is the GCS reducing? Is there any altered reflexes in the pupils? Are the pupils becoming dilated? Are there any lateralizing signs that might indicate head injury? And of course, remember, features of head injury are going to be exacerbated by hypoperfusion as a result of hypotension, and also as a result of hypoxia. So thinking about the head, and then that's more intracranial head things really. But then scalp injuries, we need to thoroughly examine the scalp. Eye injuries, all these things are possible. We need to examine the eyes to try and exclude the possibility of eye trauma. And of course, if eye trauma was detected, we could then get the correct consultant in to try and evaluate that further and give the necessary treatment. Thinking about the face, the C-spine, the neck, the front of the neck as well as the C-spine. And then we need to look at the chest. Is there any signs of chest injury? Is there any pain on palpation? Does anything feel wrong? Is there good air entry? Is there normal percussion sounds? We need to examine the chest, looking for anything that might indicate chest injury. And then the abdomen. There's so many things can go wrong in the abdomen. There could be injury to the liver, injury to the spleen, injury to the kidneys, possibly giving rise to hemorrhage into the abdomen, giving rise to a low blood pressure. So a high index of suspicion for abdominal injury and abdominal examination is very important. And then the perineum. Is there blood, PR blood? Is there PU blood, blood in the urine? Is it necessary to carry out a rectal or even a vaginal examination, depending on the type of trauma? And then the musculoskeletal system. We can examine every bone in the body. We can feel all the bones, looking for abnormal position, any pain, any developing swelling or hematoma, any abnormal movements, All of these things can indicate musculoskeletal bony injuries. And then a thorough neurological examination is important. GCS, of course, but also thinking about the peripheral nervous system. Is there damage to the C-spine, or damage to the rest of the spinal cord, or damage to peripheral nerves? We can look at these things in much more detail in this more leisurely secondary examination. But once a system or a part of the body has been examined, that doesn't mean we can forget about it. We need to keep on re-evaluating these patients. And some units will re-evaluate and do a secondary survey every day in the morning just to make sure there's been no changes, just to make sure the patient hasn't deteriorated. And the back of the patient needs to be examined as well. No secondary survey is complete unless all of the vertebral column has been examined. This means we'll need to log roll the patients. This is going to take at least 4 people to do this, 1 to take charge of the head and 3 to help turn the body, plus the examiner as well. So you've got to get 4 people to do the log roll and then 1 person to do the examination in addition to that. And then we might want to do x-rays. So the standard trauma x-rays are C-spine, chest and pelvis, or anything else that indicated where there might be an injury where x-rays would become appropriate. So is there a fractured femur or a fractured tibia? Obviously those parts of the body would need to be x-rayed. And think of other investigations at this stage as well. Certainly do a blood glucose estimate if that's not been done before. Other bloods. Are we going to need more sophisticated scanning like CT or MRI? Or if there's an abdominal injury, are we going to need something like a FAST scan, an ultrasound scan? Focused assessment sonography in trauma, FAST scanning, can reveal any free blood in the peritoneal cavity. And always bear in mind the standard things once you've got time, like keeping records. Get consent from the patient or immediate relatives as soon as possible. And then bear in mind that there might be, in some cases, forensic implications of the trauma if the patient's been attacked or in a road traffic accident. So we might need to collect some forensic evidence as we go along. And having said all that, don't forget, always re-evaluate your patient. This is not a one-off event, it's an ongoing assessment. The patient's condition can change, so keep re-evaluating them.